Good afternoon, everybody. My name is Lidiana Nunez. I will be your moderator today. I give you a welcome to our webinars of multidisciplinary approach of chronic conditions in primary attention. I would like to mention that we have the service of interpretation. So if you want to listen to this webinar in English, you can choose or select at the bottom of your screen the button of More. Go to the part that says interpretation. You choose the English language. It's very important that you give a mute to the original language so that you can listen to the English translation, and that way you would have this option working. To start, we would like to ask you to please introduce yourselves, your name, your role, specialty, and where you work, be it a clinic, a private practice, or another organization. These webinars are brought by the Institute of Public Health in Puerto Rico, a program of the Trust for Science, Technology, and Investigation or Research in Puerto Rico. It's a project for learning through the Telementary TELP and its purpose is to connect specialists with medical centers that are academic with providers of attention for health in rural areas. As part of the general guides, we would ask you to turn on your cameras. We want to get to know you and have a closer connection. Throughout the session, you can participate by typing into the chat at any time with your questions or comments. And we remind you that this webinar will be recorded in both languages for educational means. We want to remind you that you will be getting participation certificate and credits for continuing education for nutritionists, paramedics, and doctors. If you shared this link with a colleague, we want you to get their names up to date to make sure that the continuing education credits are issued accordingly and the name of the certificate is correct. So we will do the pre-test. There will be a pop-up on the screen. I'm sorry. In a couple of minutes, you have it. Okay. If you don't see it, you can scan the QR code or the link will be shared in the chat by Julio, my colleague. This pre-test will be open throughout the presentation, so you can go answering it as we go along. For today, we have the topic of cardiac insufficiency, optimization, and follow-up by Dr. María Rodríguez, and she will be presenting the webinar of today. So I will transfer the screen to her so that she can share her own presentation. We'll give her a hello. Dr. Maria, can you hear us? Hello, yes, I can hear you. The screen is yours. So let me get my screen up. Okay, so that it's well organized. Still? Okay, super. Okay, so good afternoon. Welcome. My name is Dr. María Rodríguez Santiago. I'm cardiologist, board certified. I work in San Patricio in Guaynabo, and at your service, I will be talking about heart failure. And I will talk to you about prevalence, some data from prevalence, briefly about physiology. I will define what heart failure means, and we will focus on the treatment and how to optimize that medical treatment and what we should do to monitor our patients. First, why do we talk about this? And it's because it's a prevalent condition in the United States, about 7 million people. Let me get my timer going. 7 million people, 20 years and older, suffer from heart failure today. And we expect for that by 2030, 9 million people will be suffering of the condition. And we believe that 1 of every 40 people suffers cardiac failure in the United States. What's even more alarming is that the risk, the lifetime risk, meaning our lifetime, that the time that we have is in developing heart failure is high. Up to 1989, 4 out of 20, meaning 20%, could develop heart failure. And a group of 20 people, 5 people, have that lifetime risk, which is about a 25% probability of developing heart failure throughout their life. In 2023, heart failure was mentioned on almost 500,000 death certificates. And it was about almost 15% of all causes of death. And the median survival of patients before the most innovative therapy of the 4 pillars of heart failures was very, very low. And it was even lower the younger the patients were, because obviously part of them were that the younger the person is, we expect them to live longer. So of course, the biggest difference was there in the younger generations. So as we can see in this graph, let me put the link. The people who were between 65 and 69 had a life expectancy, if they didn't have heart failure, of about 20 years, 18%. And with heart failure, it was reduced to about 4 years, especially those who had FREP, the ones who have the pumping function reduced. So the expectation of 20 years would go down to 4. And as we getting older, as the expectation gets shorter, life expectancy, the difference was not as notable. But if the person who's 90 did not have heart failure, we would think of 5 years, and with heart failure, it would be 1. This reflects the data of before the new medication came out, the one that we will be talking about. Okay. Heart failure, the pathophysiology, is basically the manifestation of hypertrophy of the ventricle, which is the thickening of the walls of the ventricle, comes as something evolving so that the heart can be more efficient. Why? Because at first, when the heart begins to work against a higher resistance with hypertension, it develops a thickening that is concentric. That means that the sarcomeres go in parallel, which makes the heart bigger, or in Spanish, a bit fat, as we would say in Spanish. So that thickening develops and it goes into diastolic heart failure. The ventricle is so stiff and so thick, so fat, so it becomes very difficult for it to relax and open. And they're the ones who suffer from HE with different from the eccentric dilation, where we have sarcomeres that are added more in series, one behind the other. So then we have episode 1, 2, and 3. In series, it means that you have 1, 2, 3, and that makes the cavity dilate. So the thickening doesn't happen as much, but the cavity, since we have it one behind the other and not next to each other, then this is how morphologically it looks in the ones with reduced ejection fraction. And why is it an adaptation? Because if we look at this, the walls of the heart, as the wall thickening increases, and this is the denominator, as that happens, the wall stress, or the amount of energy that the ventricle needs to engage in to pump blood, the wall stress reduces. In the same way, if we increase the radius, which is up in the numerator or above, and if we reduce the radius, then the wall stress will also decrease. So everything really starts with as a physiological adaptation of using less energy. So again, wall thickening increases a lot, the denominator goes up, the wall stress goes down, and then the chamber and radius also. Okay? Eventually, obviously, when the heart starts dilating so much, that ceases to be useful. And then we have other criteria like the Starling law that a dilation that is so big stops being useful and it no longer is an adaptation mechanism. So what begins as an evolving mechanism becomes a problem. The hemodynamics of the heart, the normal one, depend on two important factors. First, the heart rate, or the heart frequency, which is how many beats per minute we have. And on the other hand, the stroke volume, which means the volume of blood that is pumped with each beat. So we're talking about the volume of blood that is pumped per minute, and it's about 5 to 6 liters. Why is this important? Because the three factors that impact the stroke volume are what comes in through the preload, what comes in through the right side of the heart, and the afterload, which is the resistance with which the heart pumps. So high pressure, vascular problems, all of those things, and contractibility. Also, these are the ones that impact. And that is why we use these that attack these three factors. So what are the risk factors for people developing heart failure? We have them here. Coronary artery disease, high blood pressure, diabetes, and other factors like being overweight, cardiac arrest, diagnostic failure. It's a sum findings in physics and in the history of the patient. We can add echocardiograms, more information that we will get than we have. We will use diagnostic tools. But the reality, with a good history, we can have a diagnosis and we can have a good gamma of labs and diagnostic tests. These criteria are the Framingham criteria, and they establish that to do the diagnosis, you need two major criteria or one major and two minor criteria. What does that mean? What are the major and minor criteria? These patients that classically present lack of air, and they say, my lack of breath is usually when I go to sleep. I can't really lay down. I need lots of pillows because if I'm flat, I asphyxiate. Many patients who prefer sleeping on the sofa, those patients, that dependency to inclination, where they feel better, the more inclined they are, and less the more flat they are, that is quite classic. And it's typical of cardiac arrest or heart failure. Also, those who have more episodes of dyspnea or lack of air at night and they wake up trying to catch a breath. Pendopnea, it's another one. When they're going to tie their shoes, they feel fatigued. Patients, that's part of the history, no? Those that report that before they could do certain house activities like, cleaning and mopping, and suddenly they find themselves exhausted and exerted. So when we have the physical test and we see edemas in the lower extremities, and if we do the reflex where we press on their belly for 10 seconds. We see if there's an increase in the vein return in their neck. We check that out. We also listen to things that go adding in the exam. And the minors are the ones that we have here. Why are they minor? Because they are less specific for a particular condition. But if we put them all together, we have more information and we can create a diagnostic differential and put the heart failure as the highest differential in these scenarios. This analysis is also put into calculators. If you look for pharma criteria for heart failure and you go 1, 2, 3, 4, and it goes telling you what is the probability that that diagnosis is heart failure or corresponds to heart failure. The first thing that we need to do, obviously, is a good history and a physical exam. It's very important to ask the patients about the family history 3 generations back. And many of them, in my experience, don't really remember what their family members had, but they can say something about the heart. They say, oh, they had an enlarged heart, or so it's important because as we have more information of the family history, it's something less systemic etiology and more hereditary or familiar or family inclined. Okay, genetic. So when we see these patients, we also look for a clinical congestion. We evaluate for that. If you can hear the congestion inside or the abdomen looks a bit more inflated, or the pants that they usually use, they can't really close, that their socks that are not compression socks are a bit too tight, that tells us something, and that there might be something that has to do with the lungs or with the heart. And the labs that we're going to ask are these. We want them to have the CMP, the lipid profile, the CBC, complete blood count, lipid profile, TSH, and the iron levels. Those are the ones that are recommended. We can also perform PNPs or NT-proBNPs and an electrocardiogram. Insofar as the images go, we can have chest x-rays, and that will also give us information related to the size of the heart and the lungs, and an echocardiogram. I've had patients in both ways. There are primary doctors and internists that when they send them to the cardiologist, they have their sonogram or the echocardiogram already performed, and some doctors refer them to me with x-rays and a good evaluation from the physical exam. And they sort of allow us to order the echocardiogram. So whichever, it's a good way of referring the patients to the cardiologist. I do think that many times if you're going to refer them to a cardiologist, it's good that the cardiologist has the same cardiovascular lab, a trusted one for you as a doctor, because for us to then evaluate or treat a patient without having a clear image, it's a bit more complicated if we don't produce the image. But if you're producing one, if you're sending them with a study, do that with that same lab that the cardiologist uses. And then again, the diagnosis, the clinical diagnosis, we need the physical exam. We add imagery like echocardiograms because they give us an information that's very important for the prognosis and the management of the patient. The injection fraction, we calculate it by measuring in one of the sites of the echocardiogram how much volume of blood is being pumped per beat. So I tell them, my patients, this number that you see here, that it's 50 to 70%. The normal is 50%, a bit more in women. The normal is about 50%. And what does that mean? That means that If the camera, I have 100 milliliters of blood coming in this chamber, then that chamber needs to be able to pump at least 50% of those 100 milliliters. So that chamber should be able to pump 50 milliliters. The normal is that the heart can pump the half of the volume of blood that it receives. It ends and enters in the right side and then eventually to the left. If it's less than 50, then we're pumping less. And that's what the injection fraction is. Okay. And that way they can visualize it better because they see 50 and they think it's based on 100 and, they get scared. And this way they empower themselves with the knowledge. This is an algorithm taken from the ECC guides about how to evaluate and do a diagnosis. First, assessment, clinical history, physical exam, ikihi. Then we do the proBNP. This is a great marker with creative predictive value. With negative predictive value. If this comes out negative or low, that means that there's a high probability that it's not that. So it's a good marker that if it's negative, it's not that. The probability is very low that that's heart failure. If it's positive, then it adds more information, and that it goes with the differentiated diagnosis, which is going towards heart failure. We have the heart sonogram, gives us more information. We should have more testing in order to determine etiology. And then once we have the confirmed diagnosis of heart failure with the echocardiogram, we distinguish between heart failure with reduced echo fraction, mildly reduced injection fraction, and preserved injection fraction. And let me explain what that means.
Fraction. If the patient has a percentage less than 40% of reduced ejection fraction, heart failure will improve EF means that the patient at some point had a heart failure with a failure of less than 40%, and then in the follow-up electrocardiogram, he recovered and got to be better than 40%. And then between 40 and 49%, that's heart failure with reduced ejection fraction, and the rest are those that have more or equal to 50%. What's important here is to understand that the prospects of this patient change, and the therapy depends on this percentage of ejection fraction. And now we're going to focus on HFrEF because we don't have much time, and also because this one has most information, and this has been most studied through clinical randomized studies, and that's where most of the medical therapies have been developed. Here you will see that here's heart failure, a type of heart failure. If it's HFrEF, HFmEF, or HFpEF1, you should also have these ones that I'll explain later. You also should have a New York Heart Class Association or a functional status of the patient. And also you should have the clinical health status of the patient. Does he look healthy? Is there any congestion noted? So all of these are different last names, so to speak, the different names that we give to the diagnosis to determine which one is the projection, what are the prospects of the patient, which type of therapy we're also going to be giving. So we're going to be looking at each one of the 4 stages, and I will explain the stages. First, at stage A, these are patients that have high risk of heart failure. They don't have heart failure. The patients that have hypertension, diabetes, obesity, some exposure to, they have some cardiomyopathy in their family, but they do not have heart failure. And they don't have any symptoms of that either. Stage B, these patients may have certain symptoms of ejection fraction of the pumping force of the heart has diminished. They may not have it, but these patients already have some structural changes in their heart. So these structural changes could be an increased on the left-right. They could have mild, moderate, or severe hepathy. They may also have the right ventriculus that are larger. So the electrocardiogram may show that their force of pumping is different. But they do not have symptoms. Now, from stage C and going forward, these patients already have symptoms. And once they have those symptoms, we cannot return. Once the patient came to the hospital with symptoms, they will stay at stage C for a long time, and stage D, you already have advanced heart failure, and another treatment strategy is needed. Each of the stages has a different therapy that is appropriate for each stage. This is another name that we assign to describe the patients with heart failure. This is a function class of the New York Health Association, and that describes the types of symptoms and their functional capacity. You can use New York Class Association. Let's say we had a patient of symptom stage C, and assign the stages. So class 1 is somebody that can perform physical activity without major symptoms. Class 2 are those patients who, when doing regular physical activity, do not have symptoms, but if they do more, they do have symptoms. And class 3 are those patients who perhaps they're okay when they're not doing anything, but if they take a shower or if they have to clean the house, that's when they start having issues. And then the fourth class is the one that has problems even when resting. What are the most common ones? We divide them into groups. First of all, the first common ones, which is coronary artery disease, which is ischemic cardiomyopathy. And the one that is seen here, about 70% of the patients show that. And about 30% have non-ischemic causes, which is the ones listed here in the table. And those are either hereditary, family driven, and that's why we ask a lot going back 3 generations to see if prior generations had experiences with heart failure, because then it's useful to do genetic testing. Now let's review each stage. Stage A are the patients that are at risk. Those that have diabetes or hypertension, what do we do with these patients? First of all, so it's stage A, but they don't have heart failure. So the guide of ACC focused on developing a model for prevention so that we would catch them on time. It does not to be an exclusive classification for patients with heart failure. It's a way to make us more aware so that we don't lose these high-risk patients. Most of the patients that we see have stage A. So these are the patients that have some family, they have some history of infarcts, they may have strokes, they may have peripheral issues. So what is the plan for these patients? What is the plan that we should have for their management? First, we have to control their blood pressure to be under 130, 180. We have to see if they're qualified for indications for SGLT2, and also look at the latest guidance of SSCA DHA, because the cholesterol guidelines have changed. So we have to check to see how they're doing on that. And also we have to check the A1C goal based on the American Endocrinology Society. So this is what each one of those points mean. So let's see who benefits from stage A and how can they benefit from CGLT2 inhibitors. These are the patients that can benefit most from SGLT2I. These are the patients we mostly see as primary practitioners and also cardiology. And this is a stage where we have an opportunity to help our patients, to help the population to prevent development of heart failure. I divide these patient groups in 4 groups. 3 of those are diabetes defined, and the 4th is chronic kidney disease. Among the groups of diabetic patients, we have diabetics with established cardiovascular disease, so they could have had a stroke, had a heart failure 2.2. It's someone that has diabetes, does not have cardiovascular history, but they have other type of complications. And then the third type is diabetes with some cardiovascular risk factors. So here we can use this therapy to decrease the risk of hospitalizations. And so for type 2, for point 2, we can assist in lowering the risk of chronic kidney disease progress. And then on this type 3, we can prevent new onset heart failure. And for the last point, point 4, in case of chronic kidney disease, regardless of whether they have diabetes or not, if the patients have albuminuria of less or equal 300 mg per day, or even moderate, and the chronic kidney disease from stages 1 or 4, they all can benefit from SGLT2I. It's dapagliflozin or empagliflozin with this dosage. Both can help with prevention efforts. The inhibitors, CGLT, they help to lower absorption of sodium. They basically they travel through the tube, and therefore they end up exerted through urine, and therefore these patients have um, a higher incidence of complications, and it's expected that the pressure can be lowered a little bit. It does have some effect, 3 to 5 points of mercury can be lowered. The GFR, eGFR can drop slightly. And as we see in the labs, the creatine can increase by 30%. So if creatine was, let's say, at 1, and then we performed testing a month later, and now it's at 1.3. So having a dip of 30% or less is normal increase. So these drugs can also cause some mild weight loss of 1 to 3 kilos. And also in the first weeks, it can increase the frequency of urination. So these findings usually do not require discontinuation of the medicine. And this is very important. Those patients that use these drugs, they have to stop using them 3 to 4 days before the surgery if they have this condition. Now let's look at stage B. Those patients that have structural changes, they don't have symptoms. So you could have enlarged cart, you could have decrease of ejection fraction to lesser than 30%. And let's talk about the medicine that is prescribed in this case. Let me show you the table here. So the patients that have ejection fraction of less or equal to 40%, they should be divided into two groups. That's the ACI and also beta blockers. Let's look at ACI inhibitors and the ARBs, and these are the examples. All this is taken out of the guidelines. This is the dosage that we starting dosage dose and then the target dose. If the patient has the ejection fraction equal of less to 40%, then the idea is to bring the dose of medication to the highest allowable dose. If EF is equal or less than 4%, I never want to oversubscribe you. That's what I tell my patients. The only condition in cardiology where the medicine that we should give you to the highest dose to protect your heart is when we deal with heart failure. So even if you have normal pressure, blood pressure, your target is not based on blood pressure. If the patient is here and you let's say you start with lisinopril at 2.5 to 5, and then if their blood pressure is fine, I I'm not giving it to you because you have hypertension or because we have to control the pressure more. This is to protect your heart and to ensure that your heart does not enlarge, and so your heart becomes stronger. So it's important to explain this to them because sometimes people stop the therapy because they measure their pressure and they see the blood pressure is okay. But that's why we have to do this with the patients with EF at equal or less than 40%. So I only consider to reduce the dosage when the creatine is over 30%. K plus is equal or larger than 5.5, or if there is a symptomatic hypertension. Another drug that we'll discuss are the beta blockers, and they have to be one of the three: carvedilol, misoprolol, metoprolol, succinate. These are the only three that are shown to reduce mortality. This is where we start, and this is the target dosage. The beta blockers are assigned not on the basis of the heart rate. It's expected the heart rate will be reduced. There could be bradycardia, and the pulse could be lower than 60, but if they feel okay, that's not a reason to stop using the medicine. So we should be focused on symptoms that are associated with the high heart rate, not just the heart rate alone. So if they feel good, if the heart rate is at 50, okay, fine. No problem. Now, if they show, I always explain it to them, it's very possible that the first week you start taking the drug, you may feel a little tired, but step by step you'll get better. So they get ready to ease into it. So of course, if the pulse goes too low, we don't want for them to if they're under 50 beats per minute, if there is a momentary, loss of conscience, or if there's advanced AV block, then of course we have to lower the dosage. Now let's look at the stage C. At this stage, we should be working with 4 drugs. And this is the therapy of 4 pillars, and we're going to talk about each one of them. Now, these patients already are symptomatic. They had some symptoms at some stage, so they never go back to the previous stage. So what are the 4 therapies? What are we going to do? We're going to uh, since we already have the echocardiogram, and they have a DF of 35%, and they had the symptoms at one point. We have to change them from layer B to the next one. You know, you have to ensure they have one of the beta blockers that decrease mortality, the ones we mentioned previously. There's also we should use MRA like spironolactone, a middle-lactotic receptor antagonist. Always we should start CGLT2 inhibitor if it has not been already prescribed, and we will bring all these four therapies to the dosage, the highest dosage that the patient can handle. So ARNIs are the angiotensin receptor neprilysin inhibitors. These drugs, I it's important for this importance. It's important to explain that they can cause hyperkalemia. They're very potent at lowering blood pressure. I have to see you can be started if K is less than 5.2. Make sure they don't use any potassium supplements and no history of renal failure. The creatinine can increase. It should not increase more than 30%. It's important if there's some patients with heart failure have hypertension. Oh, so sometimes it's easier to handle because then you can kill two birds with the same stone. They have hypertension, so you know that you can give them a much higher dosage. But those who are normal or have hypertension, it's hard to give them four drugs, all of which um, lower your pressure. So those that have normal blood pressure, you have to slow them step by step because you're not doing this. You have to explain it. You're not doing this to lower blood pressure. You're gonna see your results lower, but ignore it. If you're not feeling good, then if you feel tired, etc., then of course you have to measure your blood pressure to make sure that there's no hypertension with symptoms. But we should ensure that we do not measure it too much so they don't stop using the medicine without need. And then the therapy optimization gets complicated. If they use the AC inhibitor and then we have to change them to ARNI, we have to wait for a washout period of 36 hours. The patients that have angioedema produced by ACI inhibitor, then the drug will be contraindicated, and we should not stop solely because SBP is less than 100 if the patient is asymptomatic. Another drug, I would explain the three, and so now we're talking about mineral glucocorticoid receptor, and these are two, spironolactone and eplerenone, and these are the starting points, and these are the target dosages. We'll start them when the renal function is fine, GFR more than 30, and potassium less than 5. We have to monitor for hyperkalemia because it can provoke it. We also have to follow the levels. If you develop gynecomastia, you should change from spironolactone to eplerenone before deciding to stop MRA therapy altogether. So, how we're going to start this therapy? We're going to start all four at a very low level, and we will go up every 2 to 4 weeks. You will choose a strategy that seems most reasonable for you. There are cardiologists, the doctors who would like to start with 2 drugs, and then in 2 weeks they see the patient and add the other 2. For example, what I do is in one appointment, I'll start the 4 drugs, and I give them the letter with instructions. You'll divide them in the morning, at lunch, and dinner. Of course, it is difficult to do it so because now they have to be taking drugs 3 times a day. But this time I minimize the chance of hypertension. So in the same visit, I try the 4 drugs with them. but I tell them that you start these two this week, and then the next week you add those two, and I'll see you in 2 weeks. I think I think it's a way to make sure that the patient does not get lost, and also we optimize the therapy as quickly as possible, because if we let them go, it's going to be difficult if we postpone it too much. So what's important is that we want that to bring that doses to the highest level that can be tolerated by the patient, and it's okay to see a mild creatinine increase. Also, the blood pressure is going to go down. We cannot be scared by it. The patient should also be warned about it, of course, when this reduction in pressure is asymptomatic. The symptoms will also be different, and many patients, some are more sensitive than others. Some can be scared if they feel they're dizzy and they already feel like it's a major side effect, and then others handle it much better. You have to teach your patients. You may feel a little bit tired in the beginning. That's okay, but in the long term, your survival probability by the end of 12 months, that's what we will go in for. That's what's our goal. This is from an article that basically summarizes that there's no perfect way of starting the four-pillar therapy. The only thing it says, and it's true, there's none. There's no perfect way to do it. You can see what you're gonna start at first, and then if, for example, if your patient has normal blood pressure or low blood pressure, then you can start with MRA and CGT2-1 and then add the other ones. For example, if the patient has bradycardia, so their pulse is already at 60, so then you start with beta blockers first.
A common complication with heart failure and therapy with 4 medications, 2 of them plus the MRA, they increase the potassium levels, and that's a hyperkalemia. So we need to tell them what is the cause, what are you eating? Supplements, they're very common. And 3, what are we going to do with the therapy? Will we need to stop it? And finally, we'll consider the potassium binders to diminish them. And here I leave you the type of medication we have in the market. Paxilate is the oldest one. It's for them, it's terrible to have that because it's like a sand that you put in water. But it's available, it's very cheap, and it's everywhere, all pharmacies. So and Lokelma, which is one of the newer ones. And we have the dosage here. They're in little packages. We put them in water. And therefore, maintenance, you have 5 to 10. And we have doses of 5 to 10. And we can play with that a little bit with those packets. Okay. And finally, stage D, briefly, these patients already they're super symptomatic. They're congested all the time. They have multiple emergency rooms. Their pulse is very low. I mean, they're in the emergency room all the time. They are already kind of factor 2. So we need mechanical circulatory support therapies like this, or they need to be considered for transplants or palliative care. And here the important part. Why are we so obsessive and emphatic with the 4-pillar therapy? It's because we have seen that there is a significant reduction in mortality and the absolute risk of the patient. This red line is patient's mortality. Let me put it like this. With no medical therapy. This is no medical therapy. This one here, the one sort of blue shadow, is AC and ARB with beta blockers. And the one down here is with the 4-pillar therapy. So if we notice patients that use nothing to those who use the 4 pillars, there's an incredible decrease of almost 25%. So 25 out of every 100 patients live more than 1 year if they take those 4 medications. If they only tolerate 2, the reduction is 14%. 15 out of 100 patients have this increase in lifespan. So the more complete the medical therapy, the higher the survival with the 4-pillar therapy. Here we see the same that we said. Mortality without therapy is almost 40%, meaning 40 out of every 100 die without medical treatment. This is with ACRBs, and these, the absolute risk difference, 12 out of 100 died of heart failure. So the absolute risk difference was 25% with the 4-pillar therapy. So this is a reduction of 25%. Is one of the risk reductions that is one of the biggest ones that exists in our history, in our medical history. But this is impressive. So we can't really see this one, but these are considerations that you should take into account to decide how to improve compliance with the medication of the patients. Among them, the ones that we emphasize the most is that they walk out of hospitalization with their 4 pillars that are, they have them there, having 90-day refills for all of them so that they have good compliance, prescribe the medications, the most cost-efficient ones, written explanations, tell them what they need to do, what to expect, when to take them. I think that's basically it. And finally, patients that come to the office after having been hospitalized must be seen 7 to 14 days after, according to the guides. We need to see what the volume is, if there's a change in weight, if there's an additional need to prescribe diuretics. So we need to check the medication, do a reconciliation. This is important because some patients, during their hospitalizations, the dosages go way down or they're taken away. So it's like starting from scratch. So every time a patient is hospitalized, besides the mortality rate increasing, it's like a reset. You have to start what was taken out and then start with the dosages again and so on. So again, order the labs in order to monitor. As for lifestyle modification, they need to have a sodium restriction. Before it was really strong. So it should be between 2,300 milligrams of sodium a day. Historically, they've talked about restricting liquids. Feels like it's logic because we want to reduce the preload because of stroke volume. But there have been a lot of randomized studies that don't find a difference in the intake of water. They haven't seen a difference or an impact in mortality. 30-minute exercise, 3 to 5 times a week, about each session about 30 minutes. That's recommended. I leave this with medications to avoid with patients that have heart failure. And finally, we have to educate our patients. We need to tell them what are the symptoms that tell us about heart failure. Like from one day to the next, if you go up 2 to 3 pounds, you're retaining liquids. I tell a lot of them that they have the capacity and the knowledge, the education. I give them the diuretics to them and I tell them, look, you're going to use this prescription if you see that you go up 3 pounds from one day to the next. If your socks are a bit tight, okay, you're going to take this diuretic once or twice a day. Others do not understand those instructions. To those, the doses of diuretics, I have it standard. I say just one daily until you see me. And each visit, I evaluate the volume state of the patient. But some of them, it's important to explain how to recognize the symptoms so that we can do a little bit of self-care and have strategies. These are the references. And thank you for your attention and your time. Thank you, Dr. Rodriguez, for that presentation. For now, we don't have any questions in the chat. I invite you to use the emoji of raising your hand to make a question if you have one. The PDF will be shared and the recording will be available soon, and we will be sharing the link in the chat. Let me share the screen so that you can, until you start the questions, I will be sharing the post test so that you can go filling it up. Give you the QR code and you'll be seeing the link in the chat. And I invite you to ask any questions that you might have. This is the moment to ask if you have any questions. Take advantage of the doctor being here. Okay, I have one question from Stephanie Carrion. She would like to know if there can be a difference in the treatment after getting the results of a genetic test. Actually, no. What changes more is a very good question. The treatment continues to be the same, the 4 pillars. What changes is, well, the evaluation. Let's say if we know that it's something genetic and it's positive in those genes, then we want to screen the genes of the offsprings of the affected person to know whether they may or not develop the condition. And if X, let's say we have patient 0, if his gene, the genes of patient 0 goes there, and if the children have the genes, and we have a sonogram, and they have no cardiopathies, then we know that basically we can just continue with follow up with echocardiograms throughout their life. If the genes are negative, we know that it won't manifest in any condition because, at least genetically, mom or dad, if they didn't have the gene, they didn't get it. So the therapy doesn't change. What changes is the management of the children or the offspring, and it allows us to give our patients more information because it's very frustrating many times. Because when it's coming, well, we tell them with the anatomy, look, you have this, these arteries are blocked and these veins are blocked. So you've developed yada yada. But when you don't have an answer, when there's no etiology, it's frustrating for them and for us because it could be genetic or we kind of like, huh? So we look at the MRI, the cardiac MRI, and other things. But even in the MRI, sometimes we don't see anything. So sometimes we say, well, it looks to be more genetic and more family oriented. And so genes tells a little bit more and it gives us a bit of information for the offsprings, just information in general. Here I have another one from Christian Reyes. If the patient has a pulse between 30-40 beats per minute and is asymptomatic, is it convenient to continue with BP? I like these questions. No, 30-40 pulses. There will be symptoms, but there's an indication in that scenario of getting a those who have cardiac failure over 40%, that we gave them beta blocks and their pulse went down to 30 and they're asymptomatic, or 40. And they say, I'm not really symptomatic. We correlate it with a bradycardia. And there's a correlation. So then that's how important the therapy is. pulses that go down to 40, so on. He feels a bit tired throughout the week, you know. We say, cool, well then it's okay. But we monitor with the symptoms. If you're feeling good, great, perfect. And then depending on that, we would see about the pacemakers, no? There's another question of Ramos Rosa. What's the lowest that a patient can have with arterial pressure so that you as a doctor, let's put it this way, how low can the pressure be for you not to order the medication or to reduce it? I would say patients with heart failure are patients that tend to be, they're all over the place, but most of them in each pumping, they have, because the strength of the pumping is diminished, the output or the volume that is pumped per beat is lower. So many of them run with normal or low normal pressure, and many of them do not develop the symptoms. So it's really very case to case, because I've had patients who are with 90, 65, and they're used to it, and there's nothing there. And others that tend to be younger that are 168 and feel bad, they feel symptomatic. I don't know if it has to do with they're more active or if they want to go faster and they can't. Anyway, but there isn't a number per se. If anybody tells you a number, they're lying. It's very case sensitive. So I feel comfortable 90, 60 insofar as the patient says, I'm feeling well. I would say that the range of the majority for cardiologists to feel comfortable to say that we're not going to stop it, it's maybe 160, but it's a number from my perspective, but there isn't a specific number, no. Okay, I'll take two more questions from the chat, and with that, we will stop. If there's any question, then I will collect them, send it to the doctor, and then send it to the participant. I have a Madeline that says, what would be the most recommended? What would be the fourth most recommended for cardiac arrest? What would be, I'm sorry, what? What would be the fourth most recommended in cardiac arrest? And would there be a reduction in liquids? Madre Marte, I don't know if you want to open the mic and explain. The IV. What would be the IV fluid, not the fourth? There we go. Okay, thank you. The most recommended would be 0.9 because it has, the one we should try to avoid is the 0.45 because it has a higher level of free water, obviously. Sometimes they're very dehydrated and we have to give it to them. Other times they're, you know, with kidneys compromised. So, or we would have the ring or slat mix, depending. What's the next question, Madeline? Would there be a reduction in liquids? Yeah. I mean, to the drip. What what drip what would be the rate of the drip per hour? I got it. Actually, I can't tell you in terms of a specific rate. I do know that in patients, if we're going to give them, let's say, patients that have heart failure, if we're going to start and they were dehydrated and we have to give them something, we prefer to give very slow drip. We prefer to give them 0.9 of 250 in 250 and 250 and reassess, 250 reassess and so on and so forth, because they're more sensitive to have too much volume. So then we need to monitor that. But there isn't really a particular rate. That's more my experience with heart failure. If you need one, use the smallest one. If they need liquid, the lowest rate possible, and monitor constantly. And the last question, Claribel Sanchez, which is the most difficult. Where is your office? I am in Maramar Plaza in San Patricio Avenue. And there's 5 cardiologists, and we're in the San Patricio Heart Institute in Guaynabo. There's 5 of us in the office. Perfect. Well, thank you very much, doctor, for your presentation today. You have the satisfaction survey. So those of you who have already completed it, thank you. And thank you for coming. And I'm going forward to the next webinars. We have one on the 5th of June. The other one is the 10th of June, both at 5 p.m. They will be directed by Dr. Jose Rivera. So we invite you to sign up so that you can continue enjoying the webinars. For each webinar, you get credits for continuing education. So we invite you to register. Thank you for participating. And thank you to the interpreters for having been here today. We thank them, and we see you next time.